Upper respiratory tract infections, or URTs. You are going to see these all day, every day, in the clinic, on the wards. But here's the thing, just because they're common doesn't mean they're simple. Making that right call, antibiotics, just supportive care, or a full-blown emergency intervention, that is one of the most critical skills you are ever going to develop. So picture this. It's a scenario you're going to face multiple times a day. Your patient's got nasal congestion, a sore throat, they feel miserable, and they just want relief. So what's going through your head? Is it a virus? Is it bacterial? Does it even matter? Well, it absolutely does. Your next move here really defines not just this one patient's care, but your whole approach to antibiotic stewardship. So let's just dive right in. The goal of this explainer is to give you the hard evidence to confidently tell these URTIs apart, to make smart, high-value decisions about antibiotics, and, this is so important, to spot the red flags for a true airway emergency before it's too late. Okay, let's start with the one you'll see the most, the common cold. This is really the bread and butter of URTIs, and honestly, getting this right sets the stage for everything else we're going to talk about. The key word, the only word that matters right here, is viral. Most colds come from rhinoviruses. And remember, the symptoms, that cough, the congestion, just feeling run down, they can easily stick around for up to 2 weeks while the immune system does its job. That length of time, by itself, does not mean something more serious is going on. So here's the bottom line, and it's a big one. Antibiotics do not work for the common cold. I'm going to say that again. They are completely ineffective. And why is that? Well, antibiotics are built to attack bacterial structures, things like their cell walls. Viruses, they don't have them, so the medicine literally has nothing to target. It's not going to shorten symptoms, and it's not going to prevent a secondary bacterial infection. This idea is a central pillar of high-value care. So, what can you do for your patient? You got to focus on the symptoms. Analgesics for the aches and pains? For sure. For the nasal symptoms, you've got options like intranasal cromolyn or ipratropium. But check this out. What's really interesting is that there's surprisingly little evidence for a lot of those common over-the-counter expectorants or mucolytics. Part of our job is to steer patients towards what the evidence actually supports. Okay, let's wade into some murkier waters. This is where things get a bit more complex. It's time to put on our detective hats and figure out if bacteria have actually crashed the party, specifically when we're talking about sinusitis and sore throats. All right, for acute sinusitis, you have to remember, most of these cases are still viral. So when do we actually pull the trigger on antibiotics? Well, the guidelines give us 3 really clear patterns to look for. First, persistent symptoms just dragging on for more than 10 days with 0 improvement. Second, a really severe start. We're talking high fever plus that nasty purulent drainage for at least 3 days straight, right out of the gate. And third is that classic double sickening story, where the patient starts to feel better and then suddenly takes a nosedive and gets much worse. Now let's talk about the sore throat, or pharyngitis. This is another one of those areas where antibiotics are just massively overprescribed. But luckily for us, we have a fantastic clinical tool to guide our decision-making, the Centaur criteria. Let's just run through them real quick. You get 1 point for each of these: a history of fever, tonsillar exudates, that pus you can actually see on the tonsils, swollen and tender lymph nodes in the front of the neck, and, this one's a big clue, the absence of a cough. Things like a cough and a runny nose, they scream viral cause. And this number right here, this is exactly why we need a tool like the Centaur criteria. I mean, just think about it. At most, maybe 1 in 7 adults who comes to your clinic with a sore throat actually has strep. The huge majority of them are viral. Our default thinking should be not to treat, and we just use these criteria to find that tiny group of patients who might actually need testing. So here's how it works, and it's beautifully simple. If that center score is less than 3, you're done. No testing, no antibiotics, just focus on symptomatic care. Now, if the score is 3 or more, then you test with a rapid strep test, and you only treat if that test is positive. It's a clear path that helps us avoid giving out tons of unnecessary antibiotics. All right, we need to shift gears completely. We've been talking about common, pretty benign conditions. Now we have to talk about a rare but life-threatening upper respiratory tract infection that you absolutely, positively cannot afford to miss. And that is epiglottitis. Now, the vaccine against H. influenza has made this much, much rarer than it used to be, but it still happens with other bugs, and it represents a true airway emergency. Okay, this view from the endoscope is frankly terrifying. That swollen, angry, cherry red thing, that's the epiglottis. And you can see how it's just completely blocking the view of the vocal cords. It's basically a lid swelling shut right over the airway. This is exactly why these patients are in so much distress. So what are the red flags you're looking for? The patient will look toxic. They'll have a hard time managing their own spit, so they might be drooling. They'll have rapid breathing and stridor. That's that high-pitched noise when they breathe in as air tries to squeeze past the obstruction. And the pain with swallowing, the ogenophagia, it'll be just awful, totally out of proportion to everything else. If you see this picture, you need to be thinking about protecting their airway, like right now. Phew. Okay, we have covered a ton of ground. Let's do a quick and dirty summary of the highest yield takeaways from managing these infections. First up, sinusitis. Just remember, most cases are not bacterial. Avoiding antibiotics when they're not needed is the definition of high-value care. Only treat if your patient meets one of those 3 specific criteria we talked about. Second, pharyngitis. Use the Centaur score. If it's less than 3, the chance of strep is so low that you shouldn't test and you shouldn't treat. That simple rule is one of your most powerful tools for antibiotic stewardship. And finally, epiglottitis. You have to remember, this is an all-hands-on-deck emergency. Management means immediate parenteral. We're talking IV or injectable, antibiotics, getting the patient admitted, and constant airway reassessment, usually in an ICU with surgical backup ready to go. So let's end with this. The next time you're about to write that prescription for amoxicillin, what's the one question you have to ask yourself? It's really simple. Does this patient meet the specific, evidence-based criteria for antibiotic therapy? By making that your default question, you'll provide better, safer, and higher value care every single time.